Today, there's really two things that I thought I wanted to share with you in hopes that this can be helpful in some way. And that I wanted to talk about the way I think about recovery as an organizing paradigm. Yes, as an individual outcome, but as an organizing paradigm as well. And I also would like to speak with you today about just what do we know about racial health equity in remission and recovery. And so I started thinking about things this way. This past summer, I had the opportunity to speak to the White House. And in doing so, it forced me to think about things in a different way and start to address things in a way that needs to encompass everybody, not just the medical doctors, not just this section or that section, but how do you weigh in on the infrastructure for the US when it comes to organizing us around substance use disorders? And so part of what I'm going to show you today, it really comes from that. Now, this was already told to you. This is just a little bit about my background. I'll just tell you that my PhD is in psychology. I'm a community psychologist. That means I'm not clinical. And so I'm a researcher, long story short. And I'll tell you at the end, I'm going to tell you a little bit more about my mentor and the founding director, John Kelly of the RI, just because it's an incredible resource. And when it comes to today's talk, I'd like to just step through things along this way, tell you a little bit about kind of my idea about the way I see recovery, as well as then the role of recovery capital. So if recovery is the paradigm, there's a role of recovery capital, there's a role of recovery support services. And I see drug courts as, having a lot of similarities at times. Despite the fact that they may not always be peer-led services like recovery support services often are, there is a lot of similarities with the power that you guys harness. I'll talk a little bit about racial health equity. What does race mean in the context of science, at least? And then course of illness for substance use disorders. And then these kind of mechanisms, risk factors for racial health inequities. What do we know about that? And then I'll finish by talking about this angle of recovery-related discrimination. I hope that you find that interesting. That was a piece that got a lot of attention. It was one of my studies that was picked up in Forbes magazine and stuff. So it seems like some people in the general population might benefit from some of the work we did at the Recovery Research Institute. So recovery is really becoming more accepted and validated as a scientific medical, among scientific, medical, and government communities. We primarily, we've been driven a lot by the medical field when it comes to really formalizing definitions, at least, because certainly out in the world of recovery support services, they've been there, if not longer, doing this job. But, the medical field, they go by remission and the DSM criteria, 1 year symptom-free, with the exception of the craving, as well as we also think about on it, when you think about it in an individual level, substance use, right? Either reductions in use or maybe abstinence. The thing that these have in common is they're really about the absence of something. I kind of call them like the absence of pathology outcomes. But when I think about recovery, I think it is more than just the absence of something. It is the presence of something. It could be the presence of well-being, the presence of health. And that idea of the presence of something has really infiltrated our work at the Recovery Research Institute. Generically, I call them well-being assessments, but honestly, some of them tap more than well-being. But we often bring these things to our work. We look at the quality of life, meaning for individuals, their perception of their position in life relative to their standards and their concerns. This is a measure that's widely used in many countries, and even the U.S., which I'll show you later, can be helpful when we make comparisons with people in recovery. The brief assessment of recovery capital. So this was an iteration, if you will, that I wrote a number of years ago and published it. It's a brief 10-item assessment. I did not invent recovery capital. I simply just kind of made an iteration of it to get to again, try to allow people who have less time with patients or clients. And I think about it as like, in theory, if we were trying to figure out what are the sum total resources that somebody needs to initiate and sustain recovery, and they can come from all of these domains across personal, social, environmental, and so we also think about self-esteem, confidence in one's worth or abilities, and just happiness, the ratio of positive to negative feelings. We're in a way, what we're trying to get at over and above just remission alone, over and above abstinence-based outcomes is that, does this individual think their life is worth living? That's part of what we are able to license in when we work under a recovery paradigm. We've been told by the National Institute of Drug Abuse that the cost of substance use disorders right now is coming in about $520 billion annually. It can be broken down into a lot of lost productivity, some crime, and some health care. But what this means for us is that the paradigm that we choose to operationalize to build this infrastructure for the US has got to comprehensively address all the components associated with this price tag. This means that recovery, if this is that paradigm, this organizing paradigm, this is about global health from substance use disorders. Recovery lies at the intersection of both medical and non-medical factors. And so we need something broad enough that we can work under this. And that's what the utility as recovery as a paradigm, it can do. It can address the synergistic roles that these factors play in creating global health from substance use disorders. I wanted to talk a little bit today about this idea of recovery capital because I feel like this is a part of my work that is relevant to what you do and already are doing. And so I hope that there's something here, something here for you. When it comes to recovery capital, it's because the achievement of sustained recovery from alcohol and other drug problems, it's not just a function of medical stabilization like detox or addressing these short-term deficits in psychopathology, but by building and successfully mobilizing all of these resources that can be brought to bear on initiating and sustaining long-term recovery. These are the building blocks. These are the building blocks for recovery. This is a focus of looking at our assets. Recovery capital, as I will continue to show you, this can help mitigate the high burden of biological and psychological stress that is associated with adaptation to abstinence and remission. So broadly, I tell people recovery capital, it's a piece of recovery. It's a piece of it. It does have a direct association with remission. And it is actually now being identified very commonly as the goal and the function of recovery support services. And my hope is that you too will see, in drug courts, that this could be something useful for you as well. Now, a lot of these are different assessments for recovery capital. The one thing that I would say, and these are just a few that I find in the literature, the one thing that I'll say, David Best at the end, I feel like he has the most comprehensive one that some people on a state level are actually adopting the REC cap. He too is actually a co-author of mine. He's on the board at the Recovery Research Institute, but he's really, really dove into this. The thing that I would say, I feel like when speaking to drug courts and the idea of recovery capital is that, a lot of these assessments, I haven't had a detailed look at David Best's one. It's a fee-based one. A lot of these are focused on that individual level that I told you about, but as an organization, the power you bring at the organizational level for you to look at your function around recovery capital, the function that you do, almost an audit on what you're doing, the assets that you guys are bringing to bear, the ones that are missing, and how you're delivering those, right, on an organizational level, because a lot of these are just going to be, surveys for a person to fill out. And so that would be something to think about. How does that apply to you guys? I like the language in Kelly and Hopner. Again, that's my mentor is Kelly. Actually, Hopner is as well. That's my statistician mentor. But they had a piece in 2014 that really articulate the relationship even better than I could. Just the idea that as recovery capital builds and accrues, it also has this linear relationship, with remission. And so it increases the likelihood of sustained long-term recovery. This is a reciprocal relationship where one dimension actually is going to feed the other. Recovery capital is a protective factor. Now, this is just a nice little graph that I drew up for you to show you the theoretical association, but we can look at the real association and real people too, because a couple years ago, we did what we called the National Recovery Study. It had thousands of people in it, and it was nationally representative based off of US Census benchmarks. We screened people into this study by asking them, have you ever resolved a problem with alcohol or other drugs? So that was the common ground right there. And I just wanted to show you what it looks like. First of all, you can see go on the line going across the bottom of your screen from 0 to 40. This is the number of years that they say that it's been since they've resolved a problem with alcohol or drugs. So we had a wide sample. People have just started in their recovery with a couple months, and people have been doing this for 40 years. Now, what you'll see here is we group together all of these strength-based assessments in terms of quality of life, happiness, recovery capital, and self-esteem. That one line you see all by itself that starts at the top and then goes down, that's psychological distress. And so it's doing what you would hope in terms of going down, over time, over the number of years in recovery, starts high and goes down. This is good news. This is empowering information. This is how you can start to arm people and tell them what to expect, that this is what recovery can, and this is actually what recovery is and how it's going to get better over time. You can see at 0, when people just started their recovery, over to 40 years, this is growth. This is growth the whole way. This is how recovery looks, and we can use this to empower people. Now, what I showed you here is that recovery also takes time. This arrow points to where that quality of life assessment, that's very broadly used with a number of conditions and countries and everything. The general population, it takes about 15 years before quality of life returns to that of which in the general population for somebody who's resolved a problem with alcohol or drugs to get to the level of the general population. And so recovery takes time, but that's part of why we do what we do. When we organize in drug courts, when we organize in recovery support services, because we are trying to shorten, and we can shorten these windows. This is a study of the general population, but I need to show you something important, because if you look more closely, that's a little fuzzy. We'll have to work on that. Between the first year and years 1 and 2, do you see that dip that happens? In that first, what this tells us is like, in the first 6 months, they may actually feel worse about themselves than they did on day 1. Okay. The questions that for us to speculate, for you guys to speculate, what is happening, during that time, you can tell them you're going to need a lot of support in your first year of recovery. There's going to be times that you may feel bad, is from what we know about other people in recovery. We can prepare them, for these things. And it's anybody's guess, at this point as to what is going on there when, I've heard people talk about if maybe they start into recovery and the bubble burst, maybe they start to look back and they have clearer vision than they've had before. Maybe they see the time has passed or the damage that may have occurred during this time. But these first, this first half a year and year can be some of the hardest times while they deal with the stressors of adapting. Now let's take a look. I want to highlight for you these recovery support services, because sometimes these aren't kind of organized or presented in this way. It's kind of like, well, we know there's 12-step meetings, and that could be, That might be about it, but there's actually a lot more. My boss has put these, he published these. This was his contribution to the Surgeon General's report, was highlighting and explaining the role of recovery support services. The common thread here is that they are often peer-based services, non-professional services, not always exclusively, but for the most part, they're driven by people with lived experience. We've got, when you look at mutual help organizations, well, surely everybody here has heard of a mutual help organization. 12-step meetings are just a part of them. Part of our work that we did is we actually went and conducted systematic reviews of the scientific literature of every section of this. We did that under a SAMHSA contract, but I can't present all that today. That'll have to be for a different talk, but, just quickly touching on these things, John Kelly published a significant Cochrane review. To say significant, it was actually turned out to be huge, but, of all the scientific literature, and just found that participation in Alcoholics Anonymous leads to higher rates of continuous abstinence over the months and over the years compared to other active treatment approaches like cognitive behavior therapy. That systematic review turned out to be literally just huge. The New York Times, it was, it's in, right now it's in one of the top 5% of all research ever kind of looked at, and by certain metrics in the world. And it's because people can relate. It's because people can relate. This is not a one-off study talking about kind of mechanisms that people don't even understand what the scientist is saying. People can relate, right? Anyway, peer-based recovery support services, recovery coaches, you guys know this. We got to actually publish the review on that, the effectiveness, just in terms of what we know of them. Recovery coaches, recovery sober living environments, recovery residencies. That was the section that I led a section on that. On the effectiveness of sober living homes, looking at all the trials that we had, comparing that to another condition. These are sober, safe, healthy living environments that promote recovery. People are expected to abstain from alcohol and drug use, but it's got tremendous effects on employment, reduced criminality. The cost effectiveness of the benefit analysis is there on that. Recovery community, clinical models of long-term recovery management. This could be like, there's only so many of these, but like the recovery management checkup by Scott and Dennis, like how to, if you went through a clinical environment, these long-term recovery checkups and how good they've been compared to just discharging people as usual. Recovery community centers. We've certainly done a lot of studies on those, number of studies on those. These are like this emerging third tier on the continuum of care for substance use disorders. They really serve as like this locatable resource for people who are in or seeking recovery, and they offer the opportunity. They very much specialize in building recovery capital. Now, this is a builder of recovery capital right here. Many of them may offer access to technology, computers, employment linkages, peer-based services, a safe place to convene. The one in my town even offers access to a shower, which supports self-care in recovery. And so they really fill a gap on the continuum of care, all of these services, because treatment is going to be focused on the absence of symptomology, but these are focused on, building this recovery capital, recovery supports in educational settings, collegiate recovery programs, recovery high schools, and so these are all, on that continuum of care, because historically, we really treated substance use disorders with this episodic approach, medical detox, stabilization, some form of brief episodic treatment. But eventually we started to treat substance use disorders like a treatable yet chronic and persistent disorder. This calls for a continuing care paradigm or a recovery management approach. And that is what the role of these services, these peer-based services do. So we'll go ahead and change gears here. I'll tell you a little bit about what I know when it comes to just racial health equity in substance use disorders, and how did it even get to that? Well, about 20 years ago, there was a landmark report from the Institute of Medicine that found striking disparities in the health care that was delivered to Black Americans. This was after controlling for or equating groups on things like health insurance and income and all of the things that are relevant. And that was about 17 years ago. But this put health equity on the national stage, and it really crystallized the need for rigorous scientific approaches to minority health or health disparities between populations. And it's had incredible implications for patient safety and quality improvement. But, you know, when you break it down to more specifically our field regarding substance use disorders, you know, it's a considerable body of evidence has shown that alcohol and other drug-related problems are no exception. Racial and ethnic minorities, but Black Americans in particular, appear to suffer a disproportionate burden despite having a lower or often approximately equivalent of prevalence of substance use disorders in the general population. And so just to show you, you know, kind of what in part, what do I mean by that? So if you're just to look, okay, in this country, in the last 12 months, this is national data in the last 12 months, who's had a substance use disorder? Well, you can see if you break it here by race, you'll see that 7.7% of individuals who identify as white have hit clinical criteria for a substance use disorder, compared to about 6.9% of African Americans, 7.1% of Latinos. So substance use disorders are actually a little bit higher in general amongst individuals who identify as white. But if you start to separate it out by primary substance, alcohol use disorder versus other drug use disorders, and of course, there can be a lot of different drug use disorders, so they're still grouped into one here. You'll see again, alcohol use disorder, you know, this appears to be higher among individuals that identify as white. And when you look at the other drug use disorders, I suspect that cocaine use disorder might be driving that across the country. There are differences by neighborhoods for sure, and towns. 3.4% is a little bit higher amongst African Americans, but really, I think the reason that I show these graphs amongst is because there's plenty of questions about who's using all the alcohol and drugs in this country. I don't know about you guys, but I certainly remember in the 80s being exposed to drug campaigns on the on TV that highly featured African Americans using drugs in the inner city. But we have to be very cautious about feeding into stereotypes or allowing even just a media campaign to shape our expectations of who is doing what out there, and to be certain to make sure that these are facts that we actually can obtain and we have at our disposal. So this is just my quick 2-minute lesson here when it comes to how do you race in science, right? What does it mean in the context of science? So in two minutes here, I'll tell you that race was construed as a social construct. Okay, sometimes we have biologic, sometimes we have medical constructs, stuff like that. This was construed as a social construct. And so what we're observing when it comes to, like, if you're seeing it in a study or summarized in a report, we're observing the effects of racism, not the effects of race. Meaning, these effects are best, they're not best interpreted by its very limited biological utility or genetics. In fact, it was the genome mapping that occurred in the 2000s. They showed no genetic differences among race. And so it's genes are more specific to the human race in general. But it should not be used as a proxy for class. We used to do that a lot in research, but we've grown beyond that. It's really conceived of as a more distinct construct that functions akin to a caste system. Health inequities, they exist because of disproportionate exposure to risk and protective factors, whether it be homelessness. You know, this can be a big one. African Americans only make up about 14% or so of the population in the US, but they represent 40% of the individuals who do not have homes. And so there's that's significant. When you don't have a house, not many other things are going to go well for you when you live on the streets. Air pollution, discrimination, access to healthy food. You know, speaking about what we're going through now, you guys are talking about, just the impact of COVID on your functioning and your jobs. And part of what we've learned of the way it's, affecting people by race is that they seem to be less likely to be able to wait out the pandemic from home. They're more likely to have to go in to report, have jobs that are more likely to have to go in and report on site, less likely to have paid time off. But for scientists, the issue that we deal with when we are trying to study something that has an association with race is the reality is there are no causes of race. We're very interested in causes as scientists. When we put out our work, a causal chain, if there is or is not one, is important for us to understand. For us, it means we have to understand there are no confounders with race. I'll explain that. And these gross associations that we start with are real. When you have a health outcome and race predicts it, the associations are real, meaning, your race can affect your health. It absolutely can affect your health through various mechanisms, that part of which I highlighted, whether it be housing, access to food, or discrimination. However, it's not the other way around. Your health cannot dictate your race. And sometimes we see this mistake made in published studies. The order of operations by which anything could even be possible is not always honored. Again, race can absolutely influence your class status, but your class status cannot dictate your race. So that's what we mean by there are no causes of race. And for us as scientists, there are implications for that, and something for you to think about as well as you continue with your careers and people put material in front of you with different variables and different associations. So that's that lesson on race in science and, really what does it mean? But I want to show you a little bit next about course of illness and recovery from substance use disorders and, how this breaks down by racial health equity. So this represents for the most severe individuals when it comes to recovery, course of illness. What you'll see here is, my boss made this slide. It belongs to the Recovery Research Institute. And he pulled this together off of a lot of different studies. And, that's our job, is to try to piece things together. What you'll see here is that after the onset of an addiction, it's going to be about 4 to 5 years before help seeking, on average, these are averages, is initiated. During that time, there might be a number of self-initiated cessation attempts before assistance in some form is actually sought. And there will be about another 8 years on average before full sustained remission is achieved. That's meaning 1 year symptom-free. There could be about 4 to 5 treatment episodes involved during that time. Again, recovery support services are involved during that time until full sustained remission. After that, there is another about approximately 5 years that will go by before the risk of meeting criteria for substance use disorder drops below 15%. Why 15%? Because that's when you're no more likely than anybody else in the general population to have a substance use disorder. So you can see that it takes time, but when you work here and in these areas, we can shorten these windows. And the other thing you'll notice is about 60% of individuals with an addiction will achieve a full sustained remission. Recovery is the most likely outcome. You can say that to people. This is a fact, and it is empowering. And we've put a lot of time and effort in order to understand that, graph that, see if that is true, to see what is the most likely outcome. But let's take a look. The director of the Recovery Research Institute did that, but it inspired me to organize the field of racial health equity along a similar timeline. Instead of just having it spread across 50 studies, I've tried to bring to you a timeline. It seems to be useful, better than reading 500 pages of a report. So one of the things that we know is that individuals who identify as Black, these are just averages, there's always exceptions, these are just averages, progress from initiation of use to the onset of a disorder faster. This is an effect known as telescoping in the literature. Individuals who identify as Black have a later age of onset, that's disorder onset, in their mid-20s compared to others who onset in their late teens. Individuals who do not identify as white appear to access alcohol use disorder treatment at comparable rates as white individuals. Now I'll say, but they are not retained at the same rates. There are no shortage of studies showing you that there are treatment differences when it comes to alcohol use disorder. But over the more recent years, there's been some considerable studies, very broad studies, that are telling us that there's a lot of equality in access to alcohol use disorder treatment right now. It's not to say you aren't going to find a geographical difference here or there. I still see those, but nationally speaking, that's really what's happening. They're not retained at the same rates. We still have that issue. We don't seem to retain them in treatment like the other people who identify with other racial groups. This came from the National Recovery Study that we did. There was a paper we found that when we were just asking people about how many serious attempts did it take you to resolve this problem with alcohol or drugs, we found that Black individuals had 3 compared to everybody else who just had 2. And so again, we're starting to go down this route of like the chronicity of the disorder. And so we'll continue to paint this picture here. When it comes to Latino individuals, a lot of these facts are focused on individuals who identify as Black. You could give a whole talk on Latinx individuals as well. There's studies that show that they have a low perceived need for treatment despite meeting clinical criteria. But compared to other racial groups who also meet clinical criteria, they have a very low perceived need for treatment. It may be, they're saying sometimes they're more likely to use informal forms of support, such as family cohesion. It's not to say that that's not that you know, the degree that these things work for them or not work for them. Those are all different questions, but this is what we're learning from them, you know. And I want to, in this segment here, I'm going to specifically focus on opioid use disorder. Okay, so again, while overdoses were surging in this country, we did see increases in prescriptions for individuals who identify as white, which is what you would expect in the midst of an opioid crisis. You would see treatment go up. There was a study that was finding that increase in prescriptions was not occurring for people who did not identify as white. And so there was some type of disparity that was being created. Another study reported that white Americans were 35 times as likely to have a buprenorphine-related visit than Black Americans. As many of you know, this is a medication to treat opioid use disorder. And then here, I'm in Massachusetts, you know, and in Massachusetts, there was a study in JAMA Psychiatry that came out that found, using some good, strong data, not just self-report, but digging in medical records and everything, found that Black and Hispanic pregnant women with opioid use disorder are far, far less likely to receive any medication. And these were people who did have it diagnosed on their record. So they did present to a treatment system at some point in time, whether it be primary care treatment or a hospital. And so there are racial disparities that we're seeing when it comes to opioid use disorder. And again, we can speculate, you know, your guesses are as good as ours as to all the mechanisms that could possibly be creating that. You know, a number of mechanisms can be creating that. All right, let's see here. Black individuals are more likely to have recurrent alcohol use disorder compared to other groups at the rate of about 35% compared to 22. Likelihood of having a recurrence, which would mean after remission is achieved, because I'm using that word recurrent in a medical terminology, which would mean you have to achieve remission by then. Black individuals, you know, this is starting to get down this idea of what are the mechanisms, what are the causes of these disparities, right? I mean, if you're saying it's there, you know, it's not because of their race in biological fashion, that it's got to be something connecting the points. What's going on, right? This study tried to get at that. You know, Black individuals with less than a high school degree were twice as likely to have a persistent substance use disorder than their comparable white counterparts. You know, again, this idea of like, what could be going on here? Why is it that individuals who identify as white and have less than a high school degree, it did not matter for them in terms of having a persistent, but it did affect individuals who identify as Black. And so again, it's a jumping off point for more considerations and research to figure out, so what exactly are you tapping? This is a marker. So what exactly are you getting at here? I'll just also show you a few of these findings that came from the National Recovery Study. They don't really fit on the course of illness, but they're definitely topical. And, you know, this was this first ever nationally representative study of Americans who resolved a problem with alcohol or other drugs. It was a web-based survey. It was cross-sectional. We did it one time. And just some of the broad findings with that study that was nationally representative, we found that 46% of the individuals actually self-identify as being in recovery. All of them resolved a problem with alcohol or drugs. About 46% identify as being, they say, yes, I consider myself in recovery. We found that that was the big number we were going for. 9.1% of Americans have resolved a problem with alcohol or other drugs. That's over 22 million people. We know that a little over 50%, 54% use what we call an assisted pathway, meaning they use either treatment or recovery support services. The remaining individuals did not seek out assistance. And so they used it, what you could call an unassisted recovery. Sometimes people call it a natural recovery, but an unassisted recovery. So sometimes people use services, sometimes people don't. The difference is of who do you see show up in services, in recovery support services, or even drug courts? Individuals who are more severe. So they are not the same population, okay? They are not always the same population. Now, I put this up here for you guys because I dug in there and I wanted to see how many of them said that they had used a drug court at some point in time. 15% of the people who have in this country who have resolved a problem with alcohol or drugs have also used a drug court. And far more may have. It's just that we're only looking at the people who are willing to take a web-based survey and really participate in a research study, which is the limitation of any study. So some of the findings about recovery that I'll just highlight to you here is going to be that we looked at employment outcomes. And we found that, again, there was, I'm highlighting to you when there was a race effect, so to speak. Individuals who identified as Black or had multiple arrests were less likely to be employed compared to the rest of the sample. So access to employment was not the same, and it was driven by if you had multiple arrests or if you were Black. Now, I'll tell you what, I didn't write this in the study necessarily, but when I look at that fact, part of it tells me that when it comes to employment, being Black is what, almost as bad as having multiple arrests? We got a lot on our hands to sort out here. When it comes to attitudes for medications for opioid use disorder, my colleague Brandon Bergman led this study, and he found that individuals who identified as Black had more negative attitudes towards agonist treatment like methadone. This could speak to, again, this is your speculation, my speculation. This could be about medical mistrust. This could be about lack of medical mistrust that has brewed in the Black community over the years. I could give an entire talk on the abuses that the medical industry and through the government had done to Black individuals, and they're still taught. They're not a part of our history. The people who have lived through them are still with us. I was watching a Netflix series. Somebody showed me a Netflix show, and I realized after watching one or two episodes, it was all about the history of abuse of Black Americans from the medical field. And they expressed it through this show, and it had sci-fi and things like that. They are reteaching the lessons. They reteach the lessons. That's what I learned. And then my colleague, David Eddy, he published a paper where he found medical conditions associated, just a small list that were specifically associated with alcohol or drug use. He didn't find any racial differences there. It's not to say that for some of these, there are racial differences in the general population, but we're looking at a recovery sample. There was no differences in reports there. Now I went and I did a little analysis for you guys. This is not published. This is just, trying to see what I can find, here. So I looked at that national recovery study. Like I said, I found 15% reported using a drug court as part of their, what you could call a pathway to recovery. Have you ever used this or that service? 15% have. And so I tested a few of these kind of recovery outcomes, if you will, just to see if there were any differences. Again, this is just self-report. It's the methodology is what it is, but I found that recovery capital was the same, regardless around if anybody had used a drug court or not. And we don't know when they used a drug court. It could have been 6 months ago. It could have been 6 years ago. We don't know. Okay. And then for quality of life, it was the same amongst individuals who used a drug court or didn't use a drug court. But there was something that emerged in my analysis, and it was regarding psychological distress. Individuals who say they had used a drug court reported higher psychological distress. And, again, due to the methodology of the study, this doesn't mean that we don't know if they were higher in psychological distress going in. We're not saying that I'm not saying the court caused higher psychological distress. We wouldn't know that. We can't put together causal inferences. But what it tells us is that you guys are in charge of a group of individuals who are more vulnerable for one reason or another. Okay, they are suffering with more psychological distress. That's probably why a part of how they ended up in front of you, and just a little bit more to be a little more clear what that psychological distress means. My interpretation of it is years ago, we didn't know the prevalence levels of substance use disorders or mental health in this country. And then years ago, some researchers started doing that. But they literally can go door to door and give full-length diagnostic assessments. But another way of doing that with all these disorders that can cause stress, mental disorders, but this measure of psychological distress is really just meant as one generalized measure that kind of just combines them all. That's really, it's like, you can't give a full diagnostic assessment to everybody, but this psychological distress, it's almost like how much distress are you under, regardless if they're looking at anxiety or PTSD. So that's just a little background on the way I understand psychological distress. It was this just quick measure to get a sense from everybody who might have that, mental health condition or substance use condition. So this is more specific, to you guys. Now, as we move through research, part of what our job is, I consider our job is to be, identify prevalence levels. We look for health equity for everybody. Is there anybody who might be getting left behind for one reason or another? And if we establish any group that appears to be getting, for one reason or another, is not, we don't have equity in what we're doing. People want to know, as scientists, the next step is what we are to identify our mechanisms. Mechanisms of disparities. These are supposed to be, as scientists, they're supposed to be actionable targets, and we end up feeding them into our intervention science. These things take time, but so I also sometimes call them risk factors because it depends on how the data was all brought together. But I just want to give you a quick overview of what are the mechanisms that people are talking about? What's, these health disparities? And so what's emerged in the literature for substance use disorder? I told you about that first one. An epidemiological study that found that when you have less than a high school degree, it affected Black people differently than affected everybody else in terms of having a persistent substance use disorder. This next one, happens to also be an epidemiological study, so it was nationally representative. I think that data came from NIH. But this individual, he was looking at racial health equality and remission. And what he found at first is that it wasn't there for Black individuals. But then when they put this variable, it was technically marriage, when he put marriage into the model, which he's interpreting as social support, then Black people were just as likely to remit. We do know that individuals who identify as Black are less likely to be married. Maybe that's social support. That's what he was finding in his study. This is just some stuff that I picked for you. So this can cause a disparity right here. Black people having access to methadone and less access to buprenorphine, that can cause a disparity in the trajectories of substance use disorder. As you can imagine, when it comes to the importance of adhering to your medication, and a medication is only as effective as it is when it is taken. Having to report to a federally qualified methadone clinic, which on average is about 40 minutes away in this country, compared to buprenorphine, which you can take at home. These have very different implications for how well somebody can adhere to the medication. And my goodness, quality of life could be very different as well. So disparate access can cause health disparities in the trajectory, medical mistrust for sure. This can cause disparities in healthcare as well. But my critique more broadly, to step back and give you a critique more broadly of what I've seen come up in the literature when it comes to mechanisms of what creates inequality. I will tell you that they are the literature, the science is far too focused on behavior change at an individual and interpersonal level, because there is increasing national recognition that structural drivers are responsible for racial and ethnic disparities. They're more at the structural, organizational, maybe policy level. Okay, this may be why we've seen a limited impact on sustained improvements over time. Now, when I'm using that word structural drivers, let's just take a step back. And because I'm going to change gears here, I just want to think about and talk about just structural drivers of recovery, period. Just regardless of race, regardless of that, just structural drivers that are affecting people who need to reintegrate, who are trying to reintegrate and get their foot back in the door of life. And so, some of our work at the Recovery Research Institute has been informed by what we call these structural level factors that can affect people even after they've resolved a problem with alcohol or other drugs that might still be happening. I just took some of the headlines here that inspired my work to look at what I call recovery-related discrimination. These were just kind of literally, I just took them from the headline here, where it says many plans deny payment for patients injured when there's the presence of alcohol or unprescribed drugs in their system. They don't have to pay for it. And then another title there had somebody did an analysis of the state laws that permit intoxication exclusions in their insurance contracts. These kind of broadly are referred to alcohol exclusion policies, and they were practices adopted by many states that allow insurance companies to deny payment for services if the injuries occurred while there was alcohol or unprescribed drugs in the individual's system. So it varies very much on a state to state level how much they're enforced. How you get around that, judges have to ultimately take a stand and say you can't do this. It a lot of variation on the state level when it comes to that. But yes, we dealt with that. We deal with this. Again, here's one, not new to you guys. In terms, you understand the drug convictions can send financial aid up in smoke. Drug offenses are the only, criminal conviction with the potential to impact student financial aid, though. That's why I call this discrimination. When you can commit a more serious crime, when you can commit embezzlement, murder, burglary, and still maintain your eligibility for financial aid should you qualify, that is why I'm calling these policies discrimination. There was a federal ban. Again, you guys a lot of you've heard these, heard these things in one form or another. There's a federal ban that had prohibited nutritional assistance for those convicted of felony drug crimes for the rest of their lives. But again, because this didn't always apply to other crimes is why I call this discrimination. This generation, and I explained this, this summer speaking to the White House, and the US Surgeon General was there. He gave closing remarks, and we are very much trying to create policies that minimize harm from substance use disorders, not policies that magnify harm from substance use disorders. And I explained to them, this generation, they don't see this as a consequence of their drug use. They see this as an act of discrimination. This idea of recovery-related discrimination, I let this play out in the National Recovery Study. My boss gave me a chance to set up some questions and do some investigations here. And I asked them, this was nationally representative. There are thousands of people in the study. And since resolving your problem with alcohol or other drugs, how frequently have the following occurred because somebody knew about your alcohol or drug history? And I asked them about 25 different questions, but I can show you that I grouped them. They seem to fall more in micro discriminations versus the macro level. So micro, this level of social interpersonal exchanges, these slights, insults that occur and are still occurring despite the fact that they've resolved a problem. I didn't ask about what happened before they've resolved a problem. And the macro discriminations, again, we've talked about these can occur on organizational levels, structural levels. But let's take a look at the results in terms of, what I found there. Okay, so this is just for the micro discriminations. And what this tells us is that about 28% of people in this country who have resolved a problem with alcohol or other drugs said that I was ignored by people because they knew about my alcohol or drug history. So this is their perception. This is perceived, of course. About 46% said people assumed I was likely to relapse because they knew about my alcohol or drug history. 20% said people said I look like an alcoholic. People said I look like an addict, even though I resolved a problem with alcohol or drugs, but they knew about my history. Okay, 35% said they believed that people treated them less fairly. 38% said they were held to a higher standard because somebody knew about their alcohol or drug history. And 33% of the people who have resolved in this country, who have resolved a problem with alcohol or other drugs, said that they were disrespected, even though they had resolved a problem because somebody knew about their alcohol or drug history. Again, with these micro discriminations, 18.8% said people perceived me as being dangerous because they knew about my history. 25% people treated me like a criminal because they knew about my history with alcohol or other drugs. 31% people assumed I could not provide for myself. People avoided me. People accused me of being dishonest. 27% said that they were rejected by family or friends, while 23% said that they felt discriminated against because somebody knew about their alcohol or drug history. Now, let's take a look as to what happened when I asked them about their macro, these kind of macro level discriminations that might occur. 11% said that they left a recovery environment due to unfair treatment because somebody knew about their history. And 15% said it's been hard for me to get health insurance. 13% said I lost my job because somebody knew about my alcohol or drug history. 11% I was denied a loan or didn't even bother to apply. The reason I asked them, the reason I put in there or didn't even bother to apply is because it's not uncommon for people to know that they're not eligible for financial aid anymore if they had a run-in with the law and had an illegal substance on them. So that's why I said or didn't even bother to apply, because sometimes they already know. I was denied housing because somebody knew about my alcohol or drug history, and I was denied nutritional assistance. 7.8% said I was denied the right to vote. Now that is not specific to a federal drug crime. There's actually many things that can happen you could lose your right to vote. Things are changing. If you guys are watching what goes on in the Senate and in the legislative branch, we'll see where we end up. It's interesting, all these longstanding things that we've had. They might change, but only time will tell. I could not get a job because somebody knew about my alcohol or drug history. 10% said I had a job, but I could not get a promotion. 16% perceived that they were treated unfairly by the police because they knew about their alcohol or drug history. I received inadequate medical treatment. Well, we know that's legal, right? That's why I put some of the stuff up here. It's because we know that this is legal. And my insurance would not cover some of my medical costs. 10% of the individuals who in this country who have resolved a problem with alcohol or other drugs say that their insurance still will not cover some of their medical costs. I did an analysis after that to see if the people who experience this recovery related discrimination, it was indeed associated with more psychological distress, lower quality of life, and lower recovery resources. And so it did have an association with these things. But the next question that I asked, now this is unpublished data, this is stuff that I'm getting to and I'm working on. But the next natural question to ask is going to be, when in terms of equality, does what we're seeing here play out for everybody? Does it vary by race or ethnicity as well? It's just one way of chopping up the data. And so, what I'm going to show you here is, I'll tell you, this is specifically for individuals who identified who resolved a problem with alcohol. I did this because I'll be presenting these results for the Research Society on Alcoholism. And so I decided to try to make it, relevant for them. So we're down to looking at just problem resolution for alcohol. What I found is the only racial differences I found were, again, it was not for many other racial groups. It was for individuals who identify as Black. only and consistently over and over, and so individuals who identify as Black with who had resolved a problem with alcohol were 3 times more likely to say that they left a recovery or addiction treatment environment due to unfair treatment. That theme has come up before when we said we have retention problems. Interesting, but I lost my job. Black individuals were twice as likely to say that they lost their job because somebody knew about their history. They were 3 times as likely to say that they were denied housing because somebody knew about their alcohol or drug history. These things are not affecting everybody equally, and there are consequences that play out in people's lives. Black individuals were 3 times as likely to say, I could not get a job because somebody knew about my alcohol or drug history. And they were 4 times as likely to say I had a job, but I could not get a promotion. So, and I'll say that given what we know about how racial health inequities occur, I would have exactly hypothesized that if recovery-related discrimination was disproportionately affecting people of color, it was going to be through macro level. It was not going to be so much through the individual level. So that is a very good hypothesis, and just based off of what we know. And this is what we're seeing play out here. So just a summary to kind of round things up here is that we talked about the utility of recovery as a paradigm and the way it can service us for building this U.S. infrastructure for everybody who has this place on the continuum of care, because it can address medical, non-medical components of substance use disorder. Race, when you see these reports, it's best interpreted as a social construct, and that's a summary of what I can give you by looking all across the fields, the genes, the ancestry. There is something there with ancestry, but it appears that really what we're looking at is a social effect. Individuals who identify as Black have a more chronic course of illness despite delayed onset and somewhat equivalent prevalence, depending on what disorders we're looking at here. And we also learned that these micro level discriminations, recovery related discriminations, they are the ones that were occurring more often among people in recovery compared to macro level ones. But it was the macro level discriminations that were disproportionately affecting individuals who identify as Black. I put non-white people, but that's actually specific to individuals who identify as Black. I should change that. I didn't find that effect for all non-white groups. Before I wrap it up, I told you I just needed to tell you a little bit about the Recovery Research Institute, just because I hope that it is a tool and it is an asset for you. What the director has been able to do. So at the RRI, we call ourselves, we are a nonprofit institute. We are a team of scientists. You see that we work through research, education, and outreach, but dissemination, we really take dissemination very seriously. A lot of other labs, they do their studies, they put the science on PubMed and they move on, but we have put a ton of effort in to be able to interface with people like yourselves or families and institutions. For example, we've been here, I'll show you some examples of what we're doing, but we are here basically around these issues that, because despite how widespread the problem is, there's a lot of misinformation about the most effective ways that addiction and individuals can recover. There is a lack of synthesis about what we know, and there is really a lack of credible resources that are able to accurately summarize the information in a way that people are going to be able to relate to it and understand. One of our products is going to be right here. Everybody needs to go on recoverydancers.org and sign up for the Recovery Bulletin. This is one of the easiest ways for you to stay on top of what is relevant in terms of what the science is putting out, at least when it comes to recovery. This is just an example. We send a bulletin out every month. We have a lot of doctors that work on this. We've been doing it for years. And the thing that amazes me is that, we're able to do it for free. Dr. Kelly has taken on the responsibility of figuring out how to bring us on board, how to pay us, and do all of these things so that we can do this stuff for free. So I encourage you to sign up for that and just take the time when it comes in, give it a read. It's the easiest way. People work so hard to try to stay on top of things. They go to CMEs, they do all this. I've got doctors that tell me they give it to every patient. Recoveryanswers.org to every patient. We have an addictionary. I think this is cool. We have in a dictionary, it says, if you want addiction destigmatized, we need a language that is unified. And sometimes there's even like a stigma alert. We try to just put these words in context and, just break down, so if you ever, it grows so much, it's very handy. So remember that, as a tool. And then this is just right back to the points that that I raised for you. So just kind of a summary of that again, but I just wanted to let you know for sure about recovery, the Recovery Research Institute, and the resources. People use it for all different reasons. People tell me they're writing grants, they just copy and paste. Yeah, so all different things there. But I will go ahead and I'm going to stop right there. That was a long talk, you guys. Thank you for hanging in there. But I'll go ahead and stop.
Thank you so much, Dr. Vilsaint. That was incredible. It was even more incredible hearing it the second time, because I think I was able to absorb a little bit more, because it's a lot of information. It's a lot of really good information.
Good.
And I would like to, if you're okay with it, open it up to questions from folks. We did have one question in the chat about the slides, which I know I have, so I can, with your permission, share those with everyone.
Yes, of course. Oh yeah, absolutely.
Awesome. So everyone, we will be sharing those with you. But do y'all have any questions? And if you do, please feel free to unmute yourself and ask. Floor is open for questions.
I just want to comment in that I thought it was very, very good information. Research, very, very well done. I think some of this information we kind of knew as drug courts was taking place already.